So I just introduced our panelists here. I have Michael Lee, who is our co-chair, and we have Dr. Chin Chiang and Dr. Nimit Shah. So you can introduce our team in Tock Seng and then introduce the case.
Okay, welcome to Tock Seng. Been a very good conference so far, and hopefully we'll put a good show for you guys today. Together with me is my fellow consultant, Dr. Deborah Lee. So Deborah will be helping me out in the robotic room, and inside the room there is also our scrub nurse, Sister Hui Min, and also quite a few circulating nurses, Rolando, Tony, and a big team here to support us. Before go any further, maybe I'll ask Deborah just to share the case with us first. Can we have the PowerPoint?
So our case is this 59-year-old gentleman with past medical history of hyperlipidemia. He presented to our hospital with angina. ECG just showed normal sinus rhythm. His labs were all unremarkable, HB of 14 and creatinine normal. So we did an angiogram for him. Basically, it showed triple vessel disease. The CERC, there's distal diffuse disease, LAD proximal to mid diffuse lesion there, and the RCA was tight in the mid. So we fixed the RCA. It was an IVUS-guided PCI where it was robotic-assisted, and we put in a Zyme Sierra 3548 stent proximal to mid. So today he's brought back now for stage PCI to the LAD.
Okay. And we also did, beforehand, we also did some angio-based QFR on this case. Can we show, do you have a QFR results there that we can show them? If not, okay, so this is essentially an angio-based QFR, and you can see the QFR reading here is very abnormal at 0.57. Okay, so maybe we can start the case. Deborah, can you go into it and help out? So can I now have the big screen? I want to show them the angiogram of what we already have. So this is the RCA which was stented. So I'm going to move on to show you the case today. So this is the projection of the LAD. So I think you can all appreciate the proximal LAD stenosis, and after the diagonal, there is a further lesion. So it's quite a long lesion here. I'll show you the other projections. This is right cranial. Okay, this is the caudal view. And the AP caudal view. Okay, so we got that. What I want to also show you is what I have in front of me. So maybe the camera can just show me. So I'm sitting in the control room. I'm not inside the lab, so I'm not leaded. So I'm sitting here. This big screen is very, very close to me. I have the image control here. I can move the pictures around, choose the thing I want, and reference it. I can see what's happening in the cath lab. I can go full view of what's happening in the camera inside the lab, and I can pan the camera up and down. So what I'm showing you now is the robotic arm connected to the guiding catheter. In this case, is an XB3 guiding catheter gone in from the left radial approach. Okay, so one of the advantages of robotic, of course, is the operator doesn't have to lean across the patient. So left radial is just as comfortable, if not even better, than the right radial, because the setup is slightly out of the way. So you can also see the console in front of me. I can select what I want. So I'm going to show you, because now what we have done while we're waiting to go online is we put the pressure wire down and did a quick FFR. So can we show the FFR readings from earlier, Tony? FFR, not IFR.
Paul. First,
okay,
this
so,
is Michael
yes,
speaking.
Yes.
First of all, thank you
Michael.
for showing us this. It's very unlike the usual live case that the operators have to scrub in and put on all the lead aprons, the scrub stuff, sitting behind the lab table. You are just sitting comfortably in your chair. Where's the coffee?
I am.
You should have a cup of coffee.
I'll hide it, yes.
Oh, thank you. So this is very, very different from what we usually see during live transmission.
Correct. Michael, I think, what I want to show you guys is you can see that the FFR 0.55 is very similar to the QFR 0.57 that we measured a few weeks ago. Okay, so what I want to do now is to go live. Okay, so I'm going to enable my robotic setup. So you can see on the control panel here, I see the camera can come closer. Okay, you can see that I have this one, which is controlling the guiding catheter. This is controlling the wire, and this is controlling the device, i.e. the balloon, the stand that I need to track in. They all have sensors, so if you accidentally knock it, it won't work. So, they have touch sensor, and they actually sense it. So I have a foot pedal, so I can actually screen and activate X-rays in the control room. Okay, so all these are inside the control room. I don't have to be inside to do it. Okay, so first thing I want to do is I want to go back to seeing the live case now with the wire inside the vessel. So I have the pressure wire, I have the volcano pressure wire inside, as you can see. Okay, so what I want to do is I want to go and do an IFR for you now. So can we do an IFR now, Tony? Okay. Then you can see how easy to do. I mean, no hyperemia needed. Okay, so 0.66. So what I want to do now is I want to do a IFR pullback. Okay, so I can do this robotically. So tell me when we are ready. Okay, so I'm going to screen. I'm going to start pulling back the wire using the robot. You see a little bit of jump because there is a distal lesion there, right? So this part angiographically looks okay. So we now should be coming to the bend. And we see a much sharper jump. I'm going to bring it into the guide. Okay, and I'm going to stop. So I'm going to bring this out. So Deborah, maybe you can just pull this. So you can see, can you see the, I mean, this is obviously, most of the time we won't bother doing FFR, IFR because the lesion looks pretty tight, but you can see that all the pressure drop is in the proximal LAD. So what I want to do now, if you can see what's happening inside, Deborah is now physically removing this wire for me. Yeah. So she took it out. Okay, so what she's going to do is she's going to put the workhorse wire in for me next. So in this case, I've chosen a Xion blue wire, and I'm just going to wire the LAD using the robot. And I'm going to do that. I'm going to go live very soon. Now you see this little panel on my right-hand side. So on this, I actually have various setup, and these are custom setup. I can make sure I go IVUS. So default, I have the live screen and the reference screen on my right. I have my hemodynamics. I can still see what's going on inside the lab. But sometimes, as I get older, I want things to be a bit bigger, so I can go large. I can go very large, and I can almost smell what's going on inside. So now I'm going to enable the system. I'm going to now push this wire in into the LAD. Hopefully I can do that. So it went in reasonably straightforward, gone to the septal, so I'm going to bring it out a little bit, turn the direction of the wire.
You want to talk a bit on the ROR, Paul?
Yeah, I mean, this actually has some, so you can see that it can go into more or less every single branch I want. This gone into diagonal. So there's some AI already built in wiring maneuver, and it will be improved even further. I think last year I kind of half joked that I can probably have some of the wiring gurus. Like, if I really enjoy what Paul Carr was doing, he's a Chen Foundation award person, so I like the way he wires CTO. I can actually, in theory, at a given time, learn his technique with the robot and do this way too. Okay, so I'm hoping to get this wire down, and then what I'll do is I'm going to put the IVUS down and IVUS this vessel. Okay, so this wire gone down okay. All right, so now can we have the IVUS? Now, Rolando, you need to stop moving the camera, otherwise we have a problem with the co-registration.
So Paul, IVUS is compatible with this machine?
Yeah, so the machine, because of the system, I'm going to show you the camera again. You can put the IVUS in. The devices are pushed in by a lot of pulleys and gears and all that. So if things are too delicate, it will crush it. Okay, so therefore things like OCT and some of the Boston IVUS is not compatible with this system. The robot will just chew it up. The Volcano IVUS is a little bit more robust, so it have no problem tolerating it. But I'm hoping to use this IVUS a few times, so just on the careful side, I'm going to ask Deborah to physically push this down. Hopefully it will cross. Yep, it crossed. And then I will ask her just to do a quick pullback for us. Deborah, with this decide, I pull back or you pull back? I'll pull back, okay then. So you can also see that I'm wearing a headset, so it's very important that we have a two-way communications with the lab inside. Okay, so I'm enabling everything. Tony, are we ready for pullback? So I'm going to go to my working view, and then, all right, floral, and then I'm going to start pulling back. So these are all okay. I didn't like the wire going too far. I'm going to, at the same time, bring it back a little bit.
Paul, this is Chiang. I just wanted to clarify.
Yep.
When you say that
Hi.
the Volcano
The guide is in, so I'm going to bring, yeah.
when you say Volcano IVUS, you mean the eagle eye, not the Refinity?
Correct. You are right. Okay, so it jumped a little bit. So I'm going to get my guide back in. So I have control throughout the whole system. So
Paul.
I'm going to bring the Volcano IVUS
Paul,
out.
this is Dr. Nimit Shah.
Yeah.
So while you were
Okay, so
pulling,
Deborah, can you remove the IVUS for me?
if I can ask, while you were pulling your
Deborah, can you
IVUS
take
back,
the IVUS out?
while you were pulling your IVUS
Yeah.
back, we could see the guide sucking in. Can you control that as
It
well?
did. Yeah, but did you see I actually same time back the guide out? So I have simultaneous control of the wire, the guider, and the device. So when I'm pulling and pull back, I didn't like the wire being too far. I actually same time pull the wire back. When the guide gets sucked in, I same time can pull the guide out. I can actually do all that. So now we've done the IVUS run. Can we see what the IVUS looks like? Can we do pre-registration? I'm just slightly worried that because there's a bit of a jump, so I'm not sure how useful it is. But let's see what we have anyway. Okay, so Deborah, can you actually show us, maybe I'll ask Deborah to do the analysis. Okay, so what I'm going to show you is, see if I can show you what she's doing. Just give me a minute. Oops. Okay. There you are. You see, it's by the bedside. It's set up in the bedside, so, you know, so you see what she can do. I'll put it on camera for you. So she can actually choose the frame for me. And then if you look at the control room, can we actually have another camera pointing at this screen? So in the control room, whatever she's doing, I can see it here in the control room too. So it's a two-way live communication. So if you want to measure this for me as a digital reference, and you can see how easy it is. She just literally touched the screen, and I got that. So it's 3033, okay, area of 7.8. So can you come back to a more proximal LED and see what this is? So this is tight, okay, so we move past that. I think is basically, I think the IVUS get caught then and not doing an awful lot, and until it comes out. Yeah.
Or if there was not a jump before, theoretically, because it is so precise, you can actually measure the length of the lesion as well. Am I right?
I could have, yeah. I might be able to measure this with the wire. So can we just see the osteo LED again? Can you move in a little bit, Deborah? Yeah, just round about here. Yeah, can you just give me a quick measure here? Just the lumen. Okay, all right. Okay, so that's about 3545. So if I don't like what Deborah is doing, which I do, but Tony, do you think you can just adjust this for me? Can we see the technician's hand? Go to the camera. Yeah, seeing what Tony is doing. So this is the control room. So it's two ways. So we can adjust it inside here as well. So it's a live two ways on the IVUS side. All right. So I'm now going to go back to Deborah, I'm going to go back to doing this case. And what I'm going to do, I think wiring is not too difficult. So I'm hoping to show you how I can do the measurement of the length. So Deborah, can you put me back on the robot? Can we also same time open the 2.5 balloon as well? 2.5 balloon. Okay, so I can enable everything. Can we go back to the big screen? Okay, so I'm now going to pull this wire back. Deborah, can you give me a little test? Okay, so a little bit far, so I'm going to go back a little bit. Okay, test that for me. So if this is a good, reasonable, good landing, distal landing zone, now can you look at my hand? I can reset this wire position to 0. Now I will pull this wire back to where I think I want to stop. So I'm just pulling back, 10 mm, 15, 16, and I'm just pulling the wire back. Okay, I think this is roughly right. Can you now go to AP caudal or aerial caudal, either one of the caudal view? So I want to see where, now I've pulled back 34 mm so far. Okay, so can I just do a little test? So roughly is 34. Okay, so maybe I can come back a little bit more, but I think 38 would be very reasonably comfortable. Okay, can we go back to cranial? Let me rewire this vessel.
So Paul, you
So
could do
can
this.
you appreciate what I just did?
Paul, you could do this with the balloon as well, isn't it? Without pulling the wire back.
I can. You're absolutely correct. You're absolutely correct. I can do that too. But I prefer the wire because, you know, the guy doesn't tend to get sucked in if you use the wire. Whereas using a balloon, sometimes they could get sucked in. Deborah, can you load the balloon for me? Yeah, 2.5, 20. Yeah, so we take a Pantera 2.5, 20 balloon. I'm happy to hear, I mean, lesion-wise, I don't think I need to wire the diagonal, and the origin is okay. So I'm just going to balloon up this proximal LAD, just have a palpate the lesion, and then, you know, perhaps deliver the stent. And I think a 3.5 stent probably is okay. You agree?
Yes, that's more or less right. Paul, so it's actually very accurate in that measurement. Do you, since you've been doing so many cases, do you see with this more accurate measurement, you're actually using less stents? That's what has been shown in the robotic PCI trials, right? We tend to use more stents than a robot.
Yeah, I don't think I actually done enough to really convincingly say that's the case. But I certainly think in this particular patient, we want to land the stent reasonably close to the osteo LAD and not into the left main. So I think we should be able to do this quite nicely. Okay, so my wire is too far, so I'm just to say what, I can push this balloon in quite fast by pressing the turbo button. So this balloon will fly in the guide a bit faster. So as I track the balloon down, actually you can see I can simultaneously pull the wire back, not a problem at all. So this is a good position to see the guide get pulled in, so I can back the guide out. So everything can be same time happening. Okay, can we take a picture here? You're ready to take an injection? Okay. All right, can we go up here? Yeah, just go to 7 then. Yeah, 8, 10.
Can I ask the panelists, would you all consider wiring the diagonal?
All right, and 10 seconds down.
How about would you recommend Paul to wire the diagonal?
I think the diagonal has no major osteo disease. I would not wire it.
Okay, just go up here one more time. Yeah. Yep.
Also, because we have the
Okay,
IVUS,
so
right?
follow here.
The IVUS
So
pullback
the
will also
balloon
give us some
open up very
information
nicely.
on the plaque
Okay,
around
balloon
the
down.
ostium.
So I've done my pre-dilatation, pulling the balloon out. So come out very easily, pulling balloon back in, make sure that is nicely tracking. This is the 2520 balloon, move in nicely in and out. So I think it's ready for the stent. What do you guys think? So now at this point, I will turbo the balloon out so you can see how quickly it will come out. Okay, so at this point, I'm going to pull it out. You see the balloon coming out? Yeah, so at this point, the second marker is out, so she will change it for me.
Would you want to consider
So
doing
can I stick with the
IVUS, Paul? Because I think we're
IVUS again?
moving very fast, so I think we still
Okay,
have
why
plenty
don't we
of
do
time.
that? Sure, let's do an IVUS. Deborah, are we okay to do an IVUS?
Because there's a bit of a jump at the lesion site, so I think, but probably a soft plug, but I think since we have plenty of time.
I agree. Yep. Okay, so we will probably do a co-registration of the IVUS this time. So you want an angiogram first? Yeah. Okay, so Deborah, you want to give some nitrate, maybe? Blood pressure is a touch low. You know, maybe start a bit of fluid. Okay, so maybe no nitrate, and just take a picture first to us. I'll do it. Do you want to go custom 2 and MAC 1? Maybe easier that way. Okay, custom 2. Okay, you ready? So we see a bit of dissection. Now and distal wire slightly in the branch, I think. So later on we'll maneuver the wire back. Okay, so Deborah, you can do that. Yeah. Yeah. Deborah, maybe you can help me cheat a little bit, because at this point I don't have control, so maybe Deborah, you can pull my wire back a touch and just to position it a little bit better.
Paul, suppose if the balloon won't go because it's a very calcified lesion, and then you have to resort to either rotablator or orbital atherectomy, how long would it take to switch to a rotablator?
So what I would like to do, I would like to show you later on how quick it is to pull the patient off the robotic arm and then take over the case. Okay, so I'll hope to show you that. Okay, so now I'm going to screen. You want me to do the pullback, right? That's the way you do that? Okay, so we're going to start pulling back. Tony, are you ready? Yeah.
So I think you emphasize that Dr. Paul, you can see his hand is pulling back 1 mm each time when he...
yeah, I can do that too. Yeah. Yeah. So this is probably the bifurcation. Okay. A lot of plaque here. So we should be coming to the osteo-LAD reasonably soon. This is the osteo-LAD, I think. And then we're going into the left main. Okay. This is
Paul, may I ask a question?
Yeah.
Yeah, Liu here.
Yes, of course.
Good morning.
Go ahead. Yeah.
You are doing a manual pullback. You are still doing a manual pullback through the robotic, isn't it, on the IVUS catheter?
Yeah.
Yeah.
Correct.
Have you tried the manual pullback device on the IVUS? Is it possible?
No, if you decide to use the Boston system, okay, you can manually pull back the Boston IVUS catheter. You can manually, you can also put the device in the robot if you want to do OCT. Just the machine, don't put the OCT catheter in the balloon port because it will chew it. But you can actually, there is 2 ports on the robotic arm. So this system can accommodate a second wire because they got a side port that you can actually just dock things in and clip things in and secure things. So there's no reason why you can't put an OCT catheter down and do the pullback that way. It's possible. Okay. But you you can't use the robot to pull it out, and you don't want to use the robot to push it in. That's all.
Okay. I was asking about the IVUS auto pullback, because if you do the IVUS auto pullback, you can potentially measure the lesion length. Yeah.
But theoretically, you don't have to because
Tony,
because you come back one mm per run, so you can actually have.
Tony, can we see? Okay, so we can actually, can you see the co-registration now? I'll see if I can give it to you. I will have my co-registration here. Okay, so you see the co-registration, the top 2 screen, right? You can see where the arrow is pointing. So Tony, can you move it back more proximally and find a good landing zone for me? Okay, so this is probably where I want to go. Okay, so we book, here is good. Okay, we bookmark here, let's say. So I spare Deborah the agony of doing it inside. Okay, so this is what? 3.4, 3.5, 3.6, okay? So now can we go from there to distal and see how long I need? So this answers your question, Hang Bang. Okay?
Paul is
Okay,
demonstrating the IVUS co-registration. I think the advantage is you can know exactly where you are you can match it from your IVUS finding as well as your angiogram, so you know exactly where you are.
So, thank you for, exactly. You know, based on IVUS, I know where my proximal and I know where my distal segments are, the references, and in between is 40 mm. So, you know, I can use robot to do that. I can also use this system to do that, and the numbers come up more or less the same. And so can we just quickly measure this?
So, Paul, what would you
see
rely
on?
on?
The screen is 40.
Because this gives you 40, and on robotic
close, right?
precision, you had around 33, isn't it?
34, I think.
34,
but I think on the robotic, if you remember, it didn't really quite come to the osteo LAD, so I think I got a bit of space. So, you know, I think 40 is really comfortable. Yeah. Do you want me to push my luck and go 35? I think 40, most of us will probably go 40, but I think if it's really tight, I can probably trust the robot a little bit more. So if you guys are okay with this, I think, you know, with a dissection there, I think I'll just go on the stented. So can I open an Osiro mission stent, 3040? So the mission stent is the latest version of the Osiro stent. So this is essentially the same stent, but mounted on a more deliverable system. So we'll see how it copes with the robot.
I just want to highlight as well that currently Tock Seng, we are participating in a precision GRX registry. So we are comparing how accurate we measure the length of the lesion length by conventional approach versus the robotic system. So that will give us some results in the future.
Paul, this is Chiang again.
Yes.
From the physiology
Hi,
point of view, while we were doing the stent deployment, can your colleague in the background, Tony, I think his name, can he try and you know, predict what the final IFR will be after we stent this this segment?
Yeah. Can we go back to the IFR screen early on, Tony, and just do a virtual stent there?
Do you have IFR correct in Heart Center, Jiang?
Sadly, no.
So
not
how about you, Michael? Do you have?
Estimate. Come further, down. Stop. No, come back. Back. Okay, here. Let's say I put a bracket this segment. I should have an IFR more than 0.89, comfortably 0.91. Okay, so Chiang, I'm going to go back, and Deborah already put the stent near the guide for me. So I'm going to go back and try and get this stent down. So let's see how does this behave. Ooh, the guide came out. So I want a bit more wire. Okay, and I need a bit more guide support.
The robotic system does allow 2 wires, so I think you can consider using that, Paul.
Yeah. Okay, let's see it will go.
You just allow. You can just push the guide, or you can rotate as well.
I can push and rotate. Yeah, that a little bit of calcified band there, right? Let's see, we'll go.
Yeah, actually, we
if
see
it doesn't, I will put a
napkin
31
ring of calcium on IVUS before.
It is, but just on the robot. Tell you what, let's not. You know, we have time, so I'm going to pull this stand back. I'm going to pull this stand back, and
dilate with a bigger balloon.
Dilate that. Yeah, correct. I'm going to see the guide got sucked in, so I'm going to pull the wire back a little bit, put the stand back, and pull the guide back. Yeah, and then get the guide back in. Okay, so I'm going to turbo this wide out. Can I have a score flex balloon? Maybe can I take a 2.5/15 score flex? Yeah, please.
May I ask a question?
Just modify the plug a little bit at the bend. Yes, please.
Paul, you must be so confident. You can talk at the same time while doing this. You know, and I was looking at that, I said, if we are actually on the case, you know, to see that difficulty with the stand not going down, the guy kicking back, the wires, I was saying there's a complexity of how the hand and the eyes move, right? Like what my colleague panel here said, we rotate the guide, we control the wire, we try to twist the stand. How do you do that with a robot?
I think, you know, let's be fair. You know, Deborah is obviously a pretty experienced operator in a way too, and therefore I kind of, you know, but honestly, when you train your fellows, you are not using your hands either. You are sitting in a control room telling to push things in, back things off. And so you don't actually have tactile either. It's all based on your visual and seeing what happened to the guide and everything. So in that sense, you are not disadvantaged. Or at least I don't think I'm that disadvantaged. Yes, you know, is the technology the stage where it will be better than you doing it manually? I'm sure it's not. But give it time. I think this is something which I think will have a lot of potential. So I'm going to push this Scoreflex balloon down.
Paul, if I may ask, like if you were in the lab, you think you would have been able to get the stent down without doing this further pre-dilatation manually?
Yeah, okay. Yeah, can we go up here? Sorry, let me just do this and I'll talk to you. Yeah, go up. Okay, 14. And down. So it's still a bit pinched. Let me just do one more inflation, a little bit more proximal here. Okay, go up here. Yeah. Yeah, 1.5.
Paul, when you see this napkin ring of calcium, concentric calcium, do you think a shock wave is a good solution to this?
Yes, and shock wave is compatible with this.
Yes, that's right.
We tried it. I think we probably the first one anywhere else have you know, the opportunity happened, you know, and we just did it. Okay, the balloon track felt quite nice. Just one more inflation, 16. Yeah, I think the balloon is reasonably well expanded. Okay, 10-second down. Can you just give me a little test, make sure the artery is okay? That's okay. Sorry, early on there's a question. I kind of ignore that. Can I have the question back?
Sure. This is Nimit.
What was you were asking about something?
Yeah.
Yes.
So if you were in the lab, you think you would have been able to track the stent manually without using this pre-dilatation? It would have been interesting if you would have asked Deborah to just try that.
Yeah. I did that on Wednesday. Michael was in my lab, and the robot couldn't push it in. And because I was, you know, going to run back to Seng Live for another session, I said, oh, never mind, I'll just take over the case and do it manually, thinking that I will very quickly be able to do that. But I think I couldn't do that either. So the machine does give you a pretty good support in that sense. I want to give you another example recently that I did an OPN on using the system, the OPN high-pressure balloon. 300 is good. ECT 300 is good. So can we put the stent back in? So that case, after the OPN, and some of us will have experience of balloon wire fusion, right? So that balloon was inflated at 35 bar, and I'm kind of expecting there would be balloon wire fusion. But the robot actually managed to pull the balloon out really comfortably. But when the last bit, when you need to manually strip the balloon off the wire, that was a lot of resistance. So, you know, it just goes to show that how well the robot can hold things and how strong it can push things. But there is also a safety brake, okay? If it's exert beyond certain force, it won't let you carry on anymore. It will give you an error message and stop you. So there are some safety features, so you won't be able to blindly push the device outside too far. Okay, let's see. Okay, so that's quite nice. Let's have a little test. Okay, that's good. Okay, can we go caudal? Can we little test? Okay, so I'm going to back up a little bit. Okay, I'm going to go a -1 mm at a time. Test that for me. Not too far out. Okay, we go back in. retest there for me? What do you think? We'll take a picture here, should we? Is everyone okay with this?
Yeah, looks good.
Looks
Very
good.
nice.
Okay. Okay. So can we deploy the stent? Yeah. Okay. Hold on at 10, and can we do a little test with contrast?
So 35 would have been a bit short, isn't it?
Maybe. Well, let's. I think 40 is just perfect. Okay. All right. Yeah. Can we go back to cranial, please? Patient. Okay, little test. Yeah. Okay. I think with enough, we can do the post-dilatation. Now, the guy will get sucked in here, I think. So the wire is a bit funny, so I can pull the wire back a little bit. I'm going to pull the guide out a little bit. So now, device coming out, guide coming back.
So you control the
Okay,
balloon
now guy
and
can
the
go
guy
back in.
at the same time.
Yeah. Yeah. Okay, guy going back, balloon coming back.
This is what we do manually.
Yeah. Guy coming back, balloon coming. Oops. Okay, now guy going back, balloon coming back. So reasonably okay.
Very elegantly done.
So balloon coming. Thank you. All right. So I think IVUS is 3.0, so can we stick with 3.0 NC? And we can go a bit higher pressure at the bend there where there's quite a bit of calcium and we were scoring it and all that. So maybe stick with the 3.0 balloon and do that mid LAD first, and then we take a 3.5 post-dilated. And then we will IVUS it again. That sounds okay? So once you're taking it out, Deborah, do you mind just taking a picture for me?
You can have your sip of coffee first, Paul, while we wait.
Oh, okay. Okay.
Looks good.
Yeah, it is. Yeah. Yes, please. Yeah. 3020 NC will be good.
So I think the audience will be interested to know how far what's the potential for robotic PCI in complex bifurcation, Paul? So I think, what are your thoughts on bifurcation? Are we able to do DK crush?
Yeah, you are able to do that. You are able to do DK. I have not done DK crush. I have done kissing balloon. I have done a case of tap. Those are all possible. Okay, but do bear in mind, the robot can only control one wire and one device at one time. So if you actually have two devices going in, then the second device will be based on the fellow inside. So the fellow will need to control the other one. Okay, so you might want to use the robot to push the balloon through the stent struts into the wire, but the second balloon inflation will be done manually. But it can be done, and it's actually not unusually quite often done. Okay, so let's see. Okay, and then let me just get this NC balloon down.
Paul, are you concerned about some haziness distal to the stent?
Yeah, but I can IVUS it. I can IVUS that later on and see if there's any exit problem. Okay, I'm going to wait here for a bit. Can we go to angioplasty? So let me see. Can you see the balloon is inside the stent quite nicely? Can you see the top left screen? So this is almost like a live stent vis. So we are comfortably inside the stent, right? At this point. Okay, can we go up? Yep. 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 Store this, please, and down. Okay, come back with the guide a little bit too. Okay, go up here. Yeah, 16. 16, 18. Okay, store this please, and down. Okay, go up. 18. 18. Yes, please. Yeah. Yeah. And down. Deborah, can you maybe give me a little test for me when the balloon is deflated? Yep, test it. Okay. I'm going to take this out. And then the guy can go back in a little bit. Okay. Yep, GTN. Yeah. Yeah. Very well sedated patient, isn't it? Yeah.
So Paul, is it
Blood
feasible?
pressure is a bit low, so yeah, go on.
Is it feasible to do this angioplasty with just the radiographer and a nurse being there inside who can load and reload rather than your colleague?
Correct. You are absolutely right. You're absolutely right. Okay, that's the ultimate game plan because all the fellows want to be outside and don't want to be inside. You're absolutely right. So this is what we are aiming to achieve. Okay, Hui Min can actually do some of it, but I think I wouldn't want to put her through all the stress to do this during a live transmission. Okay, Deborah, can you maybe take a picture for me? Blood pressure dropped a little bit. Yeah. Okay. All right. I'm going to stick with the plan and just do the post-dilatation first, and then we'll do the IVUS. Is that okay? So give me a 3-5 NC. Yeah, and come to caudal, please. Yep.
So while waiting for the post-dilatation part, maybe you can share what have been our experience so far in Tan Tock Seng to set up the robotic team. Because Michael is going to start his program in the Queen Elizabeth Hospital next month. So how did we start? I mean, I think some of the audience here will be interested to start their robotic program after watching this live case. Can you share our experience in Tan Tock Seng?
I think your team have to embrace this, and the whole team needs to have the buy-in. Otherwise, it is no doubt a little bit frustrating to start when you do the program. You know, a case that you should normally takes 15 minutes, now take 15 minutes to set up before you can do it. But the more you do, the faster it becomes. So there's no doubt about that. Okay, so just need to give the patient to do it, and especially the nurses needs to have the buy-in because, you know, when you actually start building them up to do this balloon, putting a balloon in and particularly taking the balloon out, sometimes you lose wire. And if you start giving them a black face and complaining big time, nobody's going to help you. We also noticed that gradually the simple case, you don't tend to use robotic because, you know, if the simple case is 15-20 minutes, robotic just setting up already taken up all the time. So those are situations that you, as you gain confidence, you'll be doing the more complex stuff, the osteostenting, the long lesions. You gradually will end up going to the more type C lesions. Okay, let's carry on. But, you know, Kai Wan, maybe you can also share, while I'm trying to get this done, maybe you can also, can we go to caudal?
Kai Wan, maybe I can ask you, apart from the setup, the machine, the robotic arm, what is the additional cost for the patient by using this machine? I think only the cassette is additional, right?
Yes. So in Tan Tock Seng, at the moment, we are just charging the patient per cassette, actually.
Okay, just let me move back to custom 2. Yes, that's it. Okay, and then let's see where this.
That's something like the price of a stent, am I right? It's more or less the same as a stent.
Yeah, that's right. So at the moment, fortunately, the patient still gets some subsidy, and sometimes we package it with the stents or balloons to reduce the cost.
Okay, can we go up here? Yeah, yeah.
So Justin Davis just joined us in the panelist poll, so feel free to discuss anything you want.
Okay, and just do a little test of contrast. Yes, okay, that's fine, and down.
Justin, you have this machine in your lab, Justin?
Yeah, we don't have the, I think
just go up.
The Corindus system. We don't have the Corindus, but we have most of the other equipment though. So yeah, the co-registration systems and
store this and
imaging systems.
This is a 3-5, right? Okay, and then I'm going to take it out. So can we load back the IVUS system and have a look? Yes, please. Rolando, can you go back to AP cranial? So Justin, we did a IFR early on, and we found that actually majority of the energy loss was in the proximal LAD. Can we just give back the IFR pullback picture so that we can have a look at it? Yeah.
Right.
The earlier one. Okay, so, but then we decided to bracket also to, based on IVUS, we actually pick a longer stent and we cover beyond the band to the mid-LAD, beyond the diagonal, big diagonal. So we already put a stent in as a 304T, and now we're going to put the IVUS back in to have a look and see we can
I think it's a great
do it again with IVUS.
It's a great artery to assess.
Deborah, maybe I will ask you just to do the manual pullback, and then we'll do the co-registration, and then maybe you can use the intrasite to do some measurement. How about that? Yeah, are we ready for pullback? Yeah, ready. Okay, pullback. So you can just imagine you are the one doing this case manually, and you have the IVUS. We're not paying attention to the stent exit. So guys, help me out. Okay, it looks okay. I don't think there's any dissection there, right? Okay.
It looks okay. I think it's hazy because it's landed in a bridging segment. But otherwise, there's no dissection.
Yeah. Yeah. So we also need to pay attention to the slightly calcific area. So here probably can be a little bit bigger, right? But I think the stent area would be good. So we then need to see whether the stent landed in the proximal LAD. Okay, reasonably happy with that. What do you guys think? Yeah, that's nice. I thought it's actually landed very nicely. You know, are you guys happy with that? Okay, can we need to do an angiogram now? Is that right? For you to get the co-registration, Tony? Okay, so we're gonna do this. Okay. All right. Can you guys see this on the top left with the angiogram? Co-registration. So can we move the IVUS catheter to the stent exit for us? Deborah, are you inside? Are you able to, I move the camera and point at you. Can you do the measurement inside for me? Possible to see what Deborah is doing, and same time having the camera pointing at Tony's screen. So we have two, can we have two? Yeah. So instead of having me, you don't need me anymore. Can one of them show Deborah is doing, and the other camera pointing at what Tony's screen? Is that possible? Yeah. Yeah. Can you see that, you know, this is really, really useful. And it's really intuitive. You know, I have to tell you that this is the second time Deborah was playing with this. But obviously, the younger people, they're a lot slicker with these apps-based and touchscreen-based than us. Okay, so now Tony is just going to move it a little bit higher, maybe just past that band. Here, how about here? Yeah, just a quick measure. Maybe let her do it. Okay, yeah, I'll just stop Tony doing that. Okay.
Paul, can you hear us?
Are you guys okay with this? Yep, I can hear you.
Yeah, I think this is a great illustration of where you've combined the data from the pullback co-registration physiology with the IVUS imaging, because I think that it illustrates the point that you know, you now know the areas of potentially to target to give you the biggest benefit and where to leave alone. But essentially, where to implant your stent, how big to have the stent, and obviously to assess if it's been successful. You know, using the imaging in this very iterative way is a very, very appropriate and good practice, I think, and you've executed here brilliantly.
Yeah, measure that. Yeah, I fully agree. I mean, physiology tell you that it needs to be done. You know where the area of going to give you the maximum benefit in terms of releasing the ischemia. But I think IVUS anatomically choose a very nice landing zone, both proximally and distally for you, so that you don't just cover that particular segment, but actually you land in reasonably healthy segment. I think this is a case that I hope managed to illustrate it. And you can see that how intuitive inside the cath lab, if you are just not thinking about robotic, but you are manually doing this case, you can just imagine, inside you do the pullback immediately. You can use the touchscreen to get all this information. So here, the very proximal LAD, the area is 10.7, and it looks pretty good to me. What do you guys think? Do you want me to do any more work?
I think it looks good, Paul.
Deborah, is the IVUS-guided out?
Jiang, you have any comments, Jiang?
Is there time for a final IFR?
Okay, is the IVUS-guided out? If not, can we take it out?
Can we see the measurement at the proximal end of the stent?
The proximal stent edge.
Proximal of the stent. Okay,
Because
so
I thought
Deborah,
that was
Tony,
underexpanded.
can we move the? Okay, can we just play it once for them? Okay, can we just play it once for them? Can you? Okay, I'm gonna play it for you.
Here.
Okay.
Go in a bit.
Yeah. Okay, so we go back in a little bit for me. Okay, well, let me come around, and I think this is the area of interest. You see, this is nice because I can move around here easily. I can be the robot here. You're not very happy here, right?
Yes.
Okay, can we quick measure that? So my stand is 3.6, 3.8. Okay, the vessel, measure the vessel. The vessel can go to 5.0, okay? Now, the stent probably can go to, on the stent expansion for the Osiro mission, the 3.0 stent can go to 3.5. So I'm keen to hear what the panelists have to say. Do you want me to go higher with a 4.0, or you want me to leave it as that? So I'm open to suggestions.
Okay, maybe we can start with Jiang.
But while you're thinking, can we look for 4.0 NC?
I think
4.8 or something like that.
based on the area alone, I think it's okay. But IFR will tell you if it's a good enough result.
So, Michael, will you go with a 4?
Well, I think the area is very nice. It's well opposed. I would say we respect the limit of the stand. It's a 3.0 stand, so I probably would leave it as that.
Yeah.
How about you, Justin?
Can I give you another picture of AP caudal? Deborah, can you get an AP caudal picture for me?
I would probably leave this, Paul. I think you've done a great job and measure the physiology. I mean, we've seen lots of cases like this whereby you can further optimize stuff if the physiology is not where you thought it would be, and maybe that's a good guide. But otherwise, from a IVUS perspective, it's solid.
Yeah. Can we pull the? Can you go back control for me?
How about you, Habang? Will you post-dilate with a 4?
No, leave it alone. It's good enough.
Okay, can you give me
you will
back, or you
post-dilate
can
or you will leave it alone?
If you look at the initial IVUS, the proximal reference diameter was 4. So I would gently go on just a nominal pressure.
With a very short NC balloon, I suppose.
Deborah, can you?
Especially looking at the ostial LED, so I want a good result there.
I probably will respect the size of the stent because it's a very proximal stent, and I feel a little bit uncomfortable blowing up to 4.0, knowing that the expansion limit is 3.5. Okay, can I? Pressure is better. Can we give a bit of nitrate, 50? Yeah, 50 nitro, and then once you've done that, maybe we'll put the IFR wire back down. We have some time, right? We can do the IFR, right? Or you have a lecture as well. So, Kaiwa, why don't you do your talk while I put the FFR down, and once you've done your talk, then maybe we'll come back to me and I'll show you again. Would that be okay?
Yeah, fine. Okay, no
Is
problem.
everyone okay with that?
Yeah.
Yeah. There's no point in seeing me putting FFR. So if I do that offline while you give your talk, then I think it's all in order. Would that be okay?
Yes. Thank you, Paul.
So can you see the big screen that I'm looking at? Okay, can you see the final IFR?
Impressive.
0.95. Okay, so I think I'm done. All right. So what I want to do finally before I log off is I want you to see what Deborah does. You know, in case somewhere along the line you want to stop the case and take over. So I'm going to ask, is Deborah ready? Ask her if she's ready.
Ready?
Okay, so you're going to see her taking the patient off. Can you start the timer? Yeah. So as you see, she is going to take the patient off the robot. Okay, so unlock, unlock, disconnect the patient from the robotic arm.
This is in case the patient suddenly deteriorate during the procedure.
Yeah,
and you have
so
to do it
whatever reason, correct, you're not happy, then you want to go back. See, that's it, stop. 22 seconds. That's all you need to take the patient off the robotic arm. Okay, so we're finishing the case now. Happy to take any questions. Okay.
Paul, if I can ask, so very elegantly done case, very well demonstrated. I can see the advantage.
Thank you.
I can see the advantage to the operator where there's no radiation, you're not wearing the lead jacket, enjoying your sips of coffee. What was the advantage here for the patient in this case?
I think landing the stent very precisely where you want, especially particularly in the osteo cases. I think, you know, being so close to the screen, you know, being able to highlight the stents and position the stent very precisely where you want is one of the main things. I think that, you know, what Michael also brought up is whether it's possible to use less stents, and therefore, you know, if you do overlap, you can probably overlap a little bit less. Again, that's advantage. But I think if I'm going to say a bit of a forward, future-looking statement, it is perfectly possible that, you know, you might be operating somewhere in, say, Kuala Lumpur, and your patient is not very well in a regional hospital with a cath lab, but not a very experienced operator somewhere like, you know, 500 miles away. You could actually operate on that patient, and I would think that using the robot, I can probably do a slightly marginally better job than a very inexperienced operator. So I can actually do all this. And if I'm going to be forward-looking, then in theory, you can also do, you know, interventional cases on patients with acute stroke. We all know that there's not enough interventionists to cover that kind of demand. So those are things that potentially can happen. But yes, immediately, as we speak in 2020, the huge advantage for the patient is probably more on the precision of positioning the stents and minimizing overlap, etc., etc. But I think for us, don't forget, you know, when you don't look after yourself, you can't look after your patients. And I know of very few interventionists who doesn't have chronic back pain. So
the other advantage I can see, Paul, is you're using the left radial. I don't think many of us will use the left radial approach. It's actually more comfortable for the patients when they get off the table with just left radial wound, so that they can use their right hand and start off their life again. So with that, thank you, Paul. It's an elegant case, very nicely done. Hopefully next year, Paul, my suggestion is you sit here doing a case in your lab with the machine in the podium.
Okay.
Okay.
Wow.
Congrats. Well done.
Michael, I'll probably let you do that first. Okay, but thank you very much, everyone.
Thank you. Thank you very much.